Thank you. Welcome, everybody. This is our Peace of Mind Planning Being Prepared at Any Age, our Advanced Directive presentation. I'm going to introduce you to our speakers. We have Lisa McInnes. She's our Value-Based Care Coordinator. We have Dr. Shippey from Internal Medicine, and we have Michael Greeno, who's our Emergency Management and EMS Coordinator. He's an EMT, so we've got an EMT, a physician. We've got someone who works very closely with the practice and practice quality and access to our care here. And then I work in patient experience, which is effectively patient relations. So if anyone's lodged a formal complaint, you probably talk to me. So, so we're going to go through a couple different perspectives when it comes to advanced care planning tonight. And starting with my section here, you'll notice we mixed it up a little bit last minute here if you're looking at the printout, but I'll be doing this section first. And this is the overview of kind of the logistics and the technical aspects of advanced directives. So we'll start out with that knowledge base, and then we'll go into some of the applications, some of the things like medical orders, like DNRs and POLST, that are actually distinct from advanced directives, but have a lot of overlap and a lot of the same decision-making thought processes. So starting out, what is an advanced directive? The state of New Hampshire recognizes advanced directives as your advanced care sort of package of two different distinct designations. The first is your durable power of attorney for healthcare, or a DPOAH, and that is who can make your medical decisions for you if you became incapacitated. So that is a legally designated person that you are assigning. And then the living will answers in pretty broad strokes, how would you want your medical care to be handled? Right, and we'll get into why I'm saying broad strokes and how we can refine that later on. For the power of attorney portion, becoming incapacitated is the key here. If you fill out your paperwork tonight and assign Michael as your durable power of attorney for healthcare, that doesn't mean that Michael can then immediately start making decisions for you. When someone's name is on that paperwork, that means that if and when you become incapacitated for something like you're in a coma or there's advanced dementia, something like that, where you really can't make autonomous decisions in your own best interest anymore, then it would be activated by a provider who's deemed you to reach that level of incapacity. But again, it doesn't mean that today when you've signed your life into Michael's hands, he can't just be like, well, I'm the DPOA, so I have a say here. That's not how it works. This is reserved for those later points and later circumstances. Thinking about who should act as your durable power of attorney for healthcare. The way the form is set up, and you do have forms in your packets here, it asks you first for a primary person and a backup person. So they don't work in tandem unless you specifically write it that way, right? It's not like a 50-50 between those two people. It's who do we go to first? So if I list again Michael as my durable power of attorney for healthcare and Lisa as my second, they are not duking it out over making my medical decisions for me when it's activated. Michael has that privilege unless he cannot be reached or has waived it and says, you know, I can't be making these decisions, I'm passing it to Lisa. There are occasions where people have sort of written and indicated that they do want people to have 50-50 decision making, right? Maybe you have two adult children and you're like, I want both my kids to weigh in. We really don't like to see that necessarily. I know it seems like the kind thing to do, but when there's that discord, one person says yes, one person says no, that gets very difficult to navigate, and it could actually be referred to probate court to resolve because from the medical standpoint, they have legitimately 50-50 power in the situation, right? So we do recommend that you think about a primary and a secondary as opposed to a cooperative model. Doesn't mean they can't talk to each other and value each other's opinions, but legally speaking, that does make it a bit easier to facilitate. You also, it has to be someone who's 18. You want to really choose someone who's going to respect your wishes, not their own. So if you are talking to your daughter maybe and you want her to be your durable power of attorney, consider whether her views on things like sustained life support match yours. If you said, I want to be a DNR, and then she comes into power and says, I want to keep you alive and resuscitate you no matter what, is that aligned with your values or hers, right? No shade to anybody's daughters, I'm a daughter. But you know, you need to think about who's gonna think this is what she would want, not this is what I want for her or for you. It's also recommended, just generally speaking, you don't have to do it it is legally okay. But if you have a financial power of attorney and a health power of attorney, that could be some conflict of interest, right? Not to get too dark, but like, well, maybe we don't need life support because I get this windfall of cash, right? So it's not that it's illegal or anything, but that is something to consider if you're like in a Lifetime movie, perhaps. The next section, a living will. I mentioned this is a very general, this is broad strokes. How would you want your healthcare to be facilitated? Really talking about end of life care. Do you want all attempts at life-sustaining treatment no matter what? You want feeding tubes, you want to be resuscitated, right? Or do you only want interventions when you have, a more positive prognosis? Okay, so again, this is the very broad strokes, and it's not a medical order, but it is putting in writing your kind of general philosophy about which lane you would choose. Keep me alive no matter what, or let's have some nuance to the situation. That's really the cut and dry of the living will. Are advanced directives required? The short answer is no. However, there are state and federal laws that promote and encourage people to take this step to maintain their autonomy past a point where they are literally physically autonomous anymore, right? You may not be in the future, maybe there was a car accident and you are no longer conscious, or you have dementia and you can't make your own decisions anymore. You can maintain your autonomy by putting these things in writing with your preferences and the people you want to speak for you. So, there are national pushes and state level pushes to get this in writing because it's the right thing for our patients and ourselves, ethically speaking. And because of that national recognition, advanced directives are valid over state lines. Every state, is sort of left to their own devices about some of the nuance, but they are largely the same kind of concept. Some other states use the word proxy, for example, or surrogate in their language, as opposed to durable power of attorney for healthcare, right? Like they're words that effectively mean the same and can be transferable state to state. That said, if you have moved, for example, if you lived in Connecticut and now you live here, you should probably establish a New Hampshire one, right, with your current physician and talking through all those things just to keep everything in line. And we do like to throw this quote in here, it always seems too soon until it's too late, right? When you're thinking about preserving your autonomy, no matter what age you are, no matter what your health status is, something unfortunate could happen where, you're thinking, I should have done this beforehand, and you never know. Not to be too sinister, but you just don't know what tomorrow is going to bring. If you do not have an advance directive, it's not that you're going to be completely left in the lurch and left to the mercy of the hospital staff or the state guardianship office. There is a sequence of people that will be tapped in to act as your healthcare proxy or your surrogate, but it goes in a specific order. So the first being your spouse, the next being your adult child, your parent if they're still alive, for example. And although this does have some semblance of logic to it in terms of who would be closest to an individual if they didn't say it specifically, right? But what if your adult child is really someone whose views you're not compatible with? What if you're estranged from them and all of a sudden they're thrown this in their lap that they need to make these really what's going to be very stressful and heartbreaking decisions, potentially, really impactful. So again, thinking about maintaining autonomy, it's not that there's no structure, but you kind of lose your voice in that structure if you don't speak up and do your paperwork.
Oh, you have a question?
I have a question.
Oh, sure.
Back to the, okay.
Mm-hmm.
We see agent of your estate, we see surrogate, we've been hearing other words as well.
Yep.
So are you stating that if I declare my sister to be my representative via advance directive, if I do that, 180 days in her service, she no longer has any influence?
No, this would be if you did not assign your sister. Okay. So if you had no advance directive paperwork, it would go through the sequence here. Who's sort of the highest level on the food chain that we can tap to be in charge? So that would be your adult sibling. So that would say, if you were married, it would be your spouse automatically. If you had an adult child, it would be your adult child before your sister. This, the 180 days that has to go through probate court to assign official, guardianship, that would be if we were left to our own devices and you didn't speak up. If you speak up, it's settled, right?
So in that context, you're using the word surrogate to suggest a person involved with the hospital decision-making process?
The surrogate would be one of these people, the person who is automatically assigned.
And yes, they would make the decision to continue your care or remove your care or apply new care, et cetera. They would be the consenting person to your situation.
Yeah.
Who appoints the surrogate?
That would be likely the medical staff, right? So if you were in the emergency department, maybe you were admitted to an inpatient floor, they would say, okay, what contacts do we have in this person's file? Who can we look up who's in this chain to be the next reasonable person? So the medical staff would have to be tapping them.
The
Yep.
suggestion is that you don't want to be here. You want to fill out the paperwork so you don't land in this position.
Right. Go ahead.
Do ex-wives or stepchildren into this?
No. So really, if you have an ex-spouse, that they no longer have the spouse title. When it comes to children, to the best of my understanding, it would be like, this is my biological child first, right? So, and it's not an exact science, right? Because sometimes there have been times where it's like, close friend is on the list. There have been times where like neighbors have been tapped for this act because it's like the only contact we have on this person's file. So it could feasibly be a stepchild, but it's kind of also who could we contact.
Molly, this is New Hampshire law.
New
It
Hampshire.
may not be the same in every other state.
Right.
But the people that I have listed with Cheshire Community Medical Center as, quote, people to contact in case of an emergency have no standing here.
Here at Monadnock Hospital?
No,
Or-
you're on this list.
Again, this is like if we have a default and you haven't told us. If we are researching.
Go to those two people or not?
The people on your emergency contact list?
Right.
Yes, that would be a primary place to go. But again, if you had a spouse, say you weren't legally divorced when you were going through it,
I understand.
yeah. So making your advance directive. Medical emergencies don't wait for retirement, right? So the real promotion here is to say, like, if you've turned 18, technically speaking, an advance directive is something that applies to you in your decision making. Because, I'm not seeing a whole lot of minors in the crowd, but when you're a child, right, and you're 17, it's like it's kind of a given that your parents are going to make your decisions for you. It's also, maybe you're a college student, you're still sort of thinking like, well, yeah, mom will take care of that for me, right? But it does apply at any age, anywhere on the age spectrum. And legally speaking, by the time you turn 18, advance directive paperwork is something to be addressed. There's also, of course, certain milestones that maybe would trigger some decision making. Maybe you filled one out 20 years ago and your sister was your best friend and you appointed her, and maybe now in the future you're less close and you'd rather have your brother or your friend or anybody else, right? So as things change over time, you can readdress these things, and whichever advance directive has been completed and is on file most recently takes precedence. So if I filled one out yesterday and I named Dr. Shippey, I could fill one out today and name Lisa, and Lisa moving forward is my durable power of attorney. Literally, how do you make an advance directive? The forms are freely available. They're in your folders tonight. In fact, we've got some extra copies. HealthyNewHampshire.org has downloadable versions for it. And functionally, to complete them, you can do it and sign it after you've answered the questions and outlined your preferences, either in the presence of a notary to sort of seal the deal and make it official, or two witnesses. So we do have notaries here tonight, for instance, that can notarize it for you, but it's not a 100% requirement that you need a notary. You could just have two people witness your signature. They just can't be the people that you're naming, right? So again, I name Lisa and Michael. Dr. Shippey could witness that for me.
Did you say Health New Hampshire or Health New Hampshire?
It is healthynewhampshire.org.
Okay,
Yes.
thank you.
And then once you do have a completed advance directive, it's important that it is actually accessible to the people who need to know it. We would, of course, hope that you have notified who you've assigned as your durable power of attorney, so they have some level of awareness, right? You could consider having a copy with them so that they would have it in hand if they needed to respond to a care situation, for example. You should have it on file with your primary care office as part of your medical record. You can certainly keep it with your lawyer in your own personal files, any other specialists that you maybe see at other hospitals, right? Cheshire came up before if you go there frequently. And also consider that if you are geographically in a service area of a hospital, if you call 911, you're pretty likely to be brought to that nearest hospital, right? So if you live in Peterborough, you call 911, you're going to be brought to Monadnock more often than not. So it would be a good idea to keep it on file here. Did I see a hand?
So do the hospitals share these lists? Like me, if I live here, but if I'm in Nashville or Boston or someplace, if they see that I'm from here, they call here?
Yes, so if you were in some sort of like emergency situation and they had some sort of breadcrumb trail to be like, all right, he lives in Peterborough, New Hampshire, you know, maybe there's a way to access this. Frequently, emergency departments will receive that kind of request, or offices will receive that kind of request to be like, oh, you're a patient of Dr. Shippey's, contact the office and see if there's any medical information that can be shared.
They don't have an access like quickly on their own
It's-
computer with a list?
No, it's not necessarily like a universally accessible document, right? Because you think about HIPAA and privacy and need to know and all of that. So there are mechanisms in the healthcare industry and the infrastructure so that when something is emergent and we need to know, even just like what medications are you on? What allergies are you on? Do you have an advance directive? Those are permitted to be shared in those circumstances. But no, it's not sort of a, I need to effectively Google.
Get somebody to get back from lunch break to answer the question.
Potentially. It is sort of a human contact interaction, yes. Yeah.
Also, if something that, if one of your loved ones is with you, and it's somebody who's named, they can probably make the process happen quicker, because they'll know, maybe they have a copy at home, maybe they have a picture of it on their phone, you know, so you,
Seems like it ought to go in some kind of a national register that.
in a perfect world.
Yeah. And, you know, not that I'm qualified to talk on health information exchanges per se, but like there are sort of like national efforts to make those communications a little more effective. But, you know, it's a work in progress as society goes forward. But point taken for sure. Go ahead.
If I wanted to put it on file at Monadnock Community Hospital, where do I go in the hospital?
Sure. So if you are affiliated with like a primary care office, that would be my number one recommendation. If you are not, and maybe you're call it a casual user, right? You go to the lab sometimes, then you would go to Health Information Services, the medical records department, and they could get that attached for you. Did you have a question?
Yeah, do they have some type of, like a medical bracelet, you know, especially if you were, say, a DNR? You know?
Right, and we are actually about to step into that territory. So there isn't one so much in terms of the durable power of attorney. However, some people make like little wallet cards or information cards that say like, you know, you have your photo ID obviously, but like my PCP is Dr. Shippey, my med allergies are penicillin, my advanced directive is my wife Sally or whatever. I don't know, there's Sally here, but right, so you can sort of leave clues, and that's something that in a little bit Michael's going to talk about too, and sort of the how we dig around to find that kind of information. All right, so with that, I am going to pass it off to Dr. Shippey, who's going to talk about medical orders that are distinct but kind of related to this conversation. Right, we talked about the living will, which is the very broad strokes of kind of your philosophy. And this comes down to, these are literal enactable medical orders, a do not resuscitate or DNR, and a POLST, physician order for life-sustaining treatment. So we'll let you.
So advanced directives are for everyone. Anyone 18 and up, I would say, should consider that. I've seen presentations, I don't have any real life examples, but I've seen presentations suggesting that we're talking about New Hampshire law, you don't necessarily know what other state law is, and I've seen presentations suggesting that when you send your kid off to college, you should have them do an advanced directive, naming you, their parent, as their surrogate, their decision maker, because if they landed in the emergency room somewhere, there's been probate issues and people filing for guardianship of that individual who's now in a coma, had an accident, whatever, at college, and I don't know what Texas law is, right? So they are for everyone. These orders are not for everyone and really have very specific applications, usually in situations where someone is either advanced age, multiple comorbidities, has reached a point in their life where they're sort of deciding that if they have an arrest, essentially die, they do not want to be brought back to this world. They want to allow that exit and natural course to happen. And so, again, not for everyone. It really is based on a personal value set as to when and where you might decide to say, I don't want to be resuscitated if I have a cardiac arrest. That could be based on all kinds of things, including people's religious preferences, et cetera. And you see something that's maybe not as significant as a DNR, but for instance, Jehovah's Witnesses don't accept transfusion, right? And so they make a decision based on their religious beliefs that that's just a part of care that they would not consent to. And some people would base their decision on resuscitation on those personal values. Jewelry was just asked about. So they do allow for and say and suggest that New Hampshire law would support that this is a legal sort of extension of the binding order from a physician or a nurse practitioner, a physician assistant, saying that the person is a do not resuscitate. And so you can have a bracelet, a necklace, et cetera, that's inscribed on the back showing that you're a DNR. Let me just see. So this is a sample do not resuscitate order. They almost universally have a little wallet card attached to them. And so you can put that in your wallet as another way that someone would be able to sort of see that you have that order and wish that you do not be resuscitated. In New Hampshire, these are big, bright pink forms. And my understanding is, Mike, correct me if I'm wrong, typically, if you have this filled out, you live independently at home, we would ask that you put that on the refrigerator. Most EMS services know that's where you go to look for those kind of documents. And they would go scan the fridge for something stuck to it on a magnet. And if there's a DNR, they wouldn't perform resuscitation efforts on that individual if they were called to the house. I always tell my patients, like, it sort of depends on how staunch your wish is, right? Do you put a bracelet on? Do you pay for that inscription versus have your wallet card? I will tell you that if you are at Shaw's and drop to the floor, bystanders with CPR training or otherwise are probably going to do what they think is the right thing to try to help you. Most people will not go rifling through your wallet first, and if they do, they're probably going to be looked at like, what are you doing? You trying to steal all their money or what? Just because they're on the floor. So it depends on the individual, right? If you're just staunchly in your belief that you don't want to be resuscitated, you should get a bracelet or a necklace or something like that. I've seen people with tattoos. I don't think they're really legally binding.
They are not.
So
I want to make that very clear.
Yeah, if EMS cracks their chest open and they tattoo DNR on their chest, they're not going to honor that.
Yeah.
They need the.
Somebody did it while they were sleeping.
So that's the lay of the land on a do not resuscitate order. So again, in my practice, in my experience, patients who cancer diagnosis, terminal illness, right? They know that they have a certain time left and their quality of life is failing, and they're going to be, if they were resuscitated to a place that is uncomfortable already. They're accepting that exit when and if it happens, and they don't want that effort made. Other folks might be just at an age where they've seen their quality of life change. They can't do all the things they used to love to do, and they've decided that, okay, at my age and with the things that I have going on in my life, I'm deciding that if I have an arrest, I just don't want to be resuscitated and brought back to that. POLST orders are different, although somewhat overlapping. POLST orders do include a component that allows you to decide about resuscitation right here. So do you want CPR or not? My experience with this, so I believe under the strict letter of the law, these are traditionally applied to people that a clinician assesses to probably be in the last year of their life. They are filled out in people that we are hedging a little bit. Obviously, we don't believe they're in the last year of their life, but they've requested to have these kind of orders in place. And so there's no, like, I'm not going to be hauled into court if I filled it out and the person is still alive in 18 months, right? So, but generally speaking, we're applying a POLST order to someone who's predicted to be towards the end of life. So it would be a little bit unusual to have this kind of order and be a full code. It's possible, it's an option, but it's a little bit unusual. These are usually patients, again, with certain diagnoses or certain conditions that they're making some decisions about how they want to be cared for, and usually restricting care, not suggesting sort of full court press. I want everything done. But it allows you to decide on resuscitation, but also other components of your care. You want everything done. You want all the things. So you are ill at home with pneumonia, you're going to get an ambulance ride, you're going to get intensive care, IV antibiotics, IV fluids, resuscitation, et cetera, et cetera. Or you could decide, I don't want to be transported to the hospital. I'll take all the care that I can get at home, including IV hydration if you can supply it effectively, antibiotics if you can treat an infection, those things I'll accept, but I don't want a feeding tube, or et cetera, right? So you can make more stipulations on a POLST order than you can on a do not resuscitate order. And it goes right down to just plain comfort. That's all I want is comfort level care.
So are you saying this is only in the last year, supposedly, of life?
To the best of our prediction, that's what I understand the letter of the law to say. But like I said, we're pretty terrible about making that prediction in a lot of cases.
We were talking to our daughters about it, and they actually, not specific, well, but they did say, tell us how many days after how many days would you like to have the thing pulled if you're,
That would probably be more along the lines of your living will, saying, I had a car accident, I'm in a coma, I'm now on life support in the intensive care unit. How many days are you willing to accept a ventilator, right? Those would probably come through a living will rather than a POLST style of document, all right? And it's important to have those conversations for sure, and that's another component of their presentation. So I already commented on that. The POLST orders, again, like living will, have become sort of a national standard, and there's general acceptance across state lines. So you fill out a POLST in New Hampshire, and 6 months you decide, I'm going to go down and live with my daughter in South Carolina and take that form with you. It should be honored in general. There's no real significant differences. Nomenclature, what they call them, the COLST, the MOLST, that might change, but the nuts and bolts of it are the same.
Massachusetts are MOLST.
So this is just a comparison, sort of outlining the differences between what we're talking about. So living will, relatively generalized, and what I tell people is that when we're evaluating a living will as it applies to someone's care, we have time on our side. The person is in the emergency room, they've stabilized, and we can read over that document or ask their surrogate and say, what would their wishes be? Would they want us to take them to the operating room to take their spleen out in this situation, et cetera, right? So we have time on our side, and it gives us some general guidelines about the individual's general sense around how they want their care to be managed in certain situations. Most people, I would say this really applies to sort of, not to be morbid, but the sort of brain dead state. I'm on life support. I don't have hope for meaningful recovery. Do I want to stay in that state? That's sort of the extreme. You can outline things that are much more directed and less sort of end of life, but that's what I would say most people are driving at in their living will, to say, I don't want certain things, and I don't want to be sustained for extended periods of time with certain things if there's no hope for meaningful recovery. And most of them make a statement that says something along the lines of, if two clinicians deem my state to be likely terminal and no hope for meaningful recovery, then I want X, Y, and Z done. Life support removed, for instance. And then the DNR, much more specific. So you drop to the floor at Shaw's. We're going to check for a pulse. If you don't have a pulse and you're a DNR, we're not going to do CPR, right? That would be EMS would just stop there and not perform those efforts. And the POLST, again, includes resuscitation orders, but allows you to expand into other components of care and be as restrictive as you might want to. Before I turn it over, any specific questions about orders? Mike.
Good evening, everybody. On the jewelry piece, I just want to make it clear, in all of my years doing this job, I have never encountered a necklace or a bracelet for DNR in this part of the state. They are very popular over on the seacoast. I've had other providers talk to me that they encounter them over there all the time, and there are other counties in the state where they are much more popular. But here in the southwest corner, we very rarely have ever encountered it. So for EMS providers, we look for them in the sense of an allergy bracelet, right? So that's what they're going to be looking for. But I highly recommend that you always have the wallet card on you if you have a DNR. The POLST do not come with a wallet card because there's too much information on them. But again, the first place that we're going to go in your home to look for information is the refrigerator. And that's not just for a DNR. That's for your next of kin, your allergies, your medication list, stuff like that. And I believe we have some,
We have some
Vial of Lives out there.
that have the highlights you can fill out.
The other thing that we're going to do is, if we do not find something, you need to understand, you can be standing in the living room and telling me about a DNR all you want. If I cannot prove it, I have got to start by law CPR. Now, I'm going to call my medical control, which means that I'm going to call a doctor at the hospital, and I'm going to get them on the phone, and I'm going to tell them that I am in this home, I have a family member here, they are telling me that they have a DNR, but they do not have it. I highly recommend that if you are in the place or you have somebody who has a DNR, make sure everybody in their world has a picture of it on their phone, because that is what we are seeing a lot now, right? Right now, I have a friend. He has 5 brothers and sisters. Mom is at the point that she has a DNR. Every single one of them carries a copy of that DNR on their phone, right? So if they're out and about, they can prove it, and then they can move on from there, okay?
Mike?
Yeah.
Real quick, so until the EMTs or whoever get that confirmation, they are going to...
We are going to start
see-
CPR.
Is
Yep.
it? Okay.
Yep, we are going to
Not
start
gonna
CPR.
wait and-
No, because waiting is basically letting the person die, right? Every second counts in that moment in time. And again, just so you are aware as well, once we do receive the orders and we stop, we are not going to be transporting your loved one, right? We are going to be calling with the law enforcement. We are going to be contacting the medical examiner. And then once that is confirmed, generally what happens is we will stay with you until the funeral home arrives with the decision that you have made where you would like your loved one taken, and we will help you from that point of view. So as well. But I also want to make sure you understand, DNR does not mean do not treat, right? If you are on hospice, if you have a DNR, if you have a POLST, and you call 911, we're coming. Right? We're coming, and we're going to perform everything that you want done for you at that moment in time. We have advanced level providers. If you have a POLST, but you still want to be intubated, my paramedics are going to intubate you. You know, I mean, we're going to do what you want us to do. Even if you are on hospice does not mean you cannot be transported to the hospital, right? Hopefully, you're in a hospice plan and you know what you want, and we're prepared to help you in any way that we can when we get to the home, right? And that's what we're going to do, is you're going to call us and we're going to come and we'll help you navigate anything that you need to navigate. POLST, we are just really starting to see them. A lot of providers have not yet seen a POLST live and in person when they are going to a home and stuff, so they are still learning about them. Younger EMS providers, believe it or not, have a better understanding of them because they're actually learning about them in class now, right? Whereas dinosaurs like me are learning about it when he's talking to me about mine. So, but we're getting the education out there as often as we can to them so that they will know, so that they will have the information that they need. So, all right, before I hand it off to Lisa, does anybody have any questions? All right. You are, man.
All right, which one goes to the, is that Poland?
Right.
This one? Okay. Okay, so having the conversation, broaching the difficult topics. Why have the conversation? To ensure your wishes for care are understood and respected. To appoint somebody to make healthcare decisions that you trust. I can't tell you how important this is because you have to trust them, but you have to also know that even though they disagree with your choice, they're going to respect your choice. And that's incredibly important. And to help your healthcare decision makers and loved ones understand what is important to you. Again, it always seems too soon until it's too late. So having this conversation ahead of something happening is very important because you get to have that conversation with any loved ones or friends or anybody important in your life that you think that you would choose to help to make these decisions. Who needs to be involved in the conversation? Whoever you think you'd like to make the decisions. It can be your spouse, a significant other, adult children, parents, spiritual leaders, friends, healthcare providers, anybody that you think has to be a part of this conversation, anybody that you trust and want there to help you. And where do you feel comfortable having the conversation? Anywhere that you feel comfortable having the conversation. Really recommend bringing a list of points to address because once you're in the conversation, it could get emotional, it could get argumentative, and you don't want to lose focus on your list of things that are important to you when the time comes. So the list really helps. And you can have the conversation in a car. If you don't want to look somebody eye to eye and have the conversation and you think it will be too emotional, have it while you're driving in a car. One thing that I had thought about earlier today was, what if you write it down? What if you say to the person that you're going to choose, write down what you think my wishes would be, and then you write down what your wishes would be and compare them and see, do they match up and how can you make it work out? And you could do the opposite because maybe you're going to be the person that they choose. Also, it was pointed out that that little guy is not old enough to make the decision for that gentleman, so he might want to pick somebody else. Okay, what can be included in your conversation? Things that you're worried about, medical conditions and prognosis, your fears and concerns or mistrust about health care, who you want or don't want involved in your healthcare decisions. That one's really important. If you feel very strongly that you don't want somebody to make a decision for you, make it very clear to the people that you want to make the decisions. And you can put that in the paperwork so that it's very clear. And the kinds of treatment you would or would not want. Like, that is really important because you want the person to respect what you decide. And it also avoids the burden of your family members or your loved ones having to argue over the decision or wondering, did they really want that? I don't know. I had a conversation last Christmas. They told me they wanted this, and then somebody else says, well, I had a conversation at Easter and they told me that they wanted this. So it really makes it's really important to include everything that you can in the conversation. Other issues that you'd like to be prepared for are legal documents for finances or property, pets or dependents. Like, who's going to take care of Scruffy? Like, do you want to give Scruffy to the uncle that hates dogs? No, you want the Scruffy to go to your niece who loves dogs. And then your spiritual and emotional or relational preferences for end-of-life care. It's all really important. So mapping it all out and having it all settled really helps before it happens and you're in the moment and everything gets a little bit too overwhelming. Okay, tips for your conversations. Listening to what the other person has to say, even if you disagree. This really helps for the person who is chosen as the DPOH. Listen to what they have to say. They're asking you to be their DPOH because they trust you. And the same goes for, if it's reversed. So you want to make sure that you're listening, you're hearing what the person says, and you're respecting what they say, again, even if you don't agree. And then you can decide who's the right fit. You want to make sure your decision makers will act on your wishes and not their own. Again, they may disagree, but if they say, I disagree, but I will respect your decision, then that's the person that you want supporting you at your end-of-life decisions. You don't have to cover everything in one conversation. You can keep talking about it. But in the meantime, you can fill out your advance directive. You can give it to us. We'll scan it into the system. And next week, if you have something you want to add to it, you can fill out a new advance directive. We'll put it in the system. It will replace the old advance directive. It's pretty easy. It's not a difficult process. You can go to your primary care, get a new form, then say, hey, do you have somebody that will come over and sign it for us? And they'll give us a call. We'll come over. We'll help you out. Or you can get 2 people to sign it for you. It's whatever you choose. Choose a DPOH who would think this is what they would have wanted, not I want this for them. I think I've really pushed that one a lot for this conversation. And now we'll have a question and answer session. I am going to encourage you, if you have the time to spend to fill out your advance directives right now, you have the time to do that. We will notarize them, we'll scan copies, we'll put some in our system here, we'll mail you the original, and if you decide to change your mind in the future, you can always fill out a new one, bring it back, and we'll fix it. I know a lot of people, including myself, have been handed advance directives. I take it home, I put it on a shelf, and I go, I'm going to do that tomorrow. And then I'm going to do that maybe this weekend. And then eventually, I'm going to have company come over, and that's sitting on a shelf, and I'm going to throw it away. And then a year later, I'm going to be handed another advance directive. So I encourage that you do it tonight if you think that you're going to procrastinate about it, and you can always change your advance directive again. So I think that's everything that we have covered. Oh, go ahead.
So I would appreciate getting your opinions about a comment my daughter made that she felt she had heard somewhere or something that it's really helpful to the person who is making the decision for you if you're in a position for that to happen, to have a specific number of weeks or something that you're in a coma before they cut you off. And I don't know if I think that that's right, and I don't have any medical background. What do you guys think about? I mean, like, I only want, if it's 2 weeks, take me off life support.
So again, right there, she's telling you how she feels about it. But this is about you and your end-of-life decisions. So she may think 3 months is the perfect amount of time to keep you on life support, but you might think 2 weeks is really all I want. So it's a decision that you need to make and that she should respect. And also, listen to the healthcare provider. If they are going to, they're the ones that are going to help drive the decision making and give options to your loved ones and tell them what they think the prognosis is. So with all of that information, that's going to help with the decision. And that's why, as much as you might want your daughter to be the person that's your DPOH, if she's going to say that's important to her, maybe you want to pick somebody else who will more align with what your decisions are.
Yeah, that's good advice. I guess she sort of is, I think, feeling like you're putting a lot of potential guilt on that person who is the DPOA. That if you're not specific, then they have to make the decision, and that's very difficult.
So I would, the last thing Lisa said is where the money's at, in my opinion. It has nothing to do with how long. It has everything to do with the prognosis, right? So if I'm the doctor at your bedside after you had a car accident, and I'm telling your daughter, in my medical opinion, and my colleague standing here agrees, that the likelihood of meaningful recovery is nil, then how long would you want life support? I mean, most people would say if the likelihood of meaningful recovery is nil, not at all. Most of us, I think, that's probably a pretty standard expectation. But if we say, geez, yeah, she had pneumonia, we brought her to the hospital, we had to intubate her, she's unconscious right now, we're sedating her, and she's critically ill, but we think we can get her through this, how long would you stay on life support, right? So I don't think, I think, and this is part of where I think having conversation with your clinician and even bringing your daughter to a visit might be valuable to say, to have her learn that, at least in my opinion, it would be much more about prognosis than putting a number on the duration of a level of care. And yes, it's a difficult place to be as a loved one to have to say, we're going to remove care. But I think if you put it in the context of prognosis, I'm willing to accept a quality of life that if I'm wheelchair bound but my brain works and I can talk to people and have conversations and read a book, that's a high enough quality of life for me. And other people would say, if I can't walk, I'd rather not stay, right? We don't always get to make those choices, but I think quality and prognosis has a lot more to do with it than very specific numbers of how long will I accept certain levels of care.
Yeah. And another aspect of it is, say you're saying, I don't want any further care. You could add, so my family members get here in time to say goodbye. You know, not just pull the plug and just have somebody give them a call and say, you know, mom is gone. You could say, well, a reasonable amount of time that they can come and say goodbye to me, if that's the closure that she wants without feeling the guilt, because it is your decision. So,
And I just want to validate from your daughter's perspective as well. Part of the whole purpose of getting these documents in place and having the conversation, almost more importantly, is because it's going to be hard no matter what, whether you're making the decision or you're watching the decision happen. But having the discussion up front at least won't rack someone with guilt in the future to be like, I don't know if I made the right call for mom or dad, right? You want to give them the peace of mind that this was thought through. So while she might be looking for a number, and you know, Dr. Shippey and Lisa explained the reason why that's not a hard and fast rule, I think having ongoing conversations with you so she can see that perspective will help her give some peace if and when she is in a position to make those decisions, because you don't want to be left in a place where you maybe will have regrets anyway, right? It's stressful, it's hard, but.
And thank you, because that was my gut feeling, was there are a lot of factors.
And the other thing to
Having a
do is,
professional opinion is good.
the other way to broach that component of the conversation is ask them to imagine themselves in that situation and explore what they would think, right? What prognosis would be adequate for them. You might find out that you think about it the same way and your expectations and what you would accept or not accept is very close. And that becomes an easy platform to sit on together and say, okay, make your decisions as if it were you and what you would want, because we're saying the same things, right?
What if there were like three adult children?
Yeah.
And you have chosen the one that you know, but should they be at least involved in any discussions to begin with, so they know?
Oh,
Absolutely.
For sure,
Absolutely.
yeah, so
Yes.
just because somebody is named as the power of attorney doesn't mean all the other kids get squat. I mean,
Well,
right?
That would be
So
really crucial, that would be, feel like
Yeah.
they're part of it in some way.
exactly, and it's really, if you think about, I'm thinking of sort of a healthy family dynamic, of course. But, you know, if you've got 3 kids and they've all had the conversation with you and they've had the conversation about, like, how many days, Mom, right? And you're all kind of on the same page, they can weigh in and discuss this. It's just, you know, if Michael's the guy, if he's the son you've dubbed, he has the one who's like, I'm going to put pen to paper here. But that doesn't invalidate, you know, and I think...
the other two may be fine saying, good, you're the one that's
Right,
trying,
great,
but-
Michael can do it. Yeah,
Well,
exactly.
You want them to know,
It's a family issue.
you want
It
them
is.
to know it's no secret.
Right.
This is the child that I chose to make the decision. These are my decisions. I want you aware of it. You don't want to surprise them at last minute and then be like, well, I thought I was the one that you had picked,
Maybe they
you know?
feel like, you
So,
know-
yeah, and the first one might say, you know what, I can't make that decision. I don't want to be that person. And then you pick the second one. But yeah, absolutely let them all know.
And assign jobs. If you have 3 children, one of them is your medical power of attorney. One of them is your financial power of attorney, right? And one of them is dubbed to be the person who's in charge of the dog and the cat after,
Yeah.
afterward. No, seriously though, right? You know, families do better that way in that dynamic because everybody is included, everybody's involved, and it works well.
No surprises. That's the best way to have
Yep.
these
Yeah.
things go. I've been in hospital rooms with situations where 2 siblings aren't seeing it eye to eye, and it is really, really messy.
Yeah, I've been in living rooms where it's come to almost blows.
Yeah.
Yeah, can only imagine.
Yeah, I have 4 kids, and I already asked them, and they're like, oh, no, we want all equally being, I'm listening to this again.
Equal
No.
thoughts, not equal decision-making power, right? The
Yeah.
legal thing is the cookie, but like everybody else
Yeah.
can still deliberate, yeah.
Yep. And the financial versus the medical,
Yeah.
always separate. It's
Yeah.
just.
I like that idea of having a job for all of them.
Yeah, it's really good. Yep.
Yeah, and you're protecting them when you separate financial and medical, right?
Yep.
Because you can imagine, someone could be called out to say, you made a decision based on your own financial gains, not what was best for Mom,
Yeah,
right?
Even if they didn't, at the end, people there's blame, and even if it wasn't the original thought,
yeah.
6 months down the line, somebody's ruminating over it, and they're like, maybe she made that decision, you know, so. Oh, go ahead. Yep.
If a DPOA makes a choice for life, to continue life, or to do life-sustaining treatments, that's counter to what
Document says.
documented.
Then what?
Does it make it any more difficult a week later for the DPOA to say, okay, I agree now to stop the life-sustaining
So-
treatment?
I'm going to say one thing and then pass it to Dr. Shippey, and that's why you really want to weigh out who you choose to respect your decision, even if they disagree, because you don't want to get to the point where this is what the paper says, but now all of a sudden I don't want to do what they asked me to do.
So, to answer your question, if the power of attorney says this week, or at the outset of the care issue, all full court press, all life-sustaining measures, and a week later decides to say, all right, so I see the error of my ways, Dad's wishes we're going to follow his wishes, that decision a week later is not more difficult. That's not the issue. The issue would be that if I'm the treating physician and I'm reading your living will that says, do not do these things, I have a moral and ethical obligation to you as my patient to follow those wishes. Now, to protect my own liabilities, I would involve the hospital legal system, legal counsel, and everybody else to make sure that if we're going to remove care against your power of attorney's statements and consent, we're going to make sure we've got our ducks lined up legally to do that. But I do, as a clinician, have a moral and ethical obligation to you and your wishes as documented on that legal document.
If we are in your home and you are incapacitated, and the person that is there is your DPOA, and they say that just before this happened, you said that you wanted CPR, we're going to do CPR. right? We are always going to come down on the side of life. Now, I'm going to get on the phone to my medical control doctor here at the hospital and go, this is the circumstance I've got. But our crews are always going to come down on the side of life if we're told that. Now, if you tell me that and you are not the DPOA, I am going to follow the legal document. And again, I will call my doctor here to get advice as to how they want me to do it. But that's how it's gonna go. It is still a legal document that this patient has signed off on.
Right. And that's just another example of why, I think we've all said at this point, making your selection carefully and thoughtfully is about who's aligned and who's kind of good under pressure, unfortunately, is a factor as well, right? Because in the heat of the moment and you're scared, it's really hard to necessarily hold on to that prior decision. So it's not that things can't change course, but when you're talking about a medical emergency, you're awaiting resuscitation, for example, time is of the essence. And so all this pre-work, all these discussions, all the thoughtful selections and being like, we hate this situation, but we are prepared for this situation is sometimes the best scenario that you can find yourself in.
Peter, did you have a question?
Yeah. If your kids are 2,000 miles away, should you be dealing with somebody locally that would answer questions in their absence?
Yeah, so if they're far away geographically, they're not available. I mean, it is possible certainly to place a phone call. Someone's in Japan. If we can get them a hold by phone, that's okay too. But I think that does go into your decision making too. Thinking about the number of days, right? And what's the prognosis. It might be easier for someone to make a decision who's like, I've been at the bedside with dad now. And I can sort of visually see and interpret in my own senses and my own self that this is the scenario, as opposed to this kind of remote, almost feels theoretical when you're so detached. So it's not that we can't navigate that as healthcare providers, but that is something that you should consider. Who's going to be with me, is accessible to me, who can meaningfully interact.
Local, since your kids can't be here, that you have confidence in and vice versa.
Yeah, so again, it's not wrong to have someone distant, but that's something that you'd have to decide your comfortability with. That's what I would recommend.
And things have changed. There's video calls now. It's a little different than, so if that person is the only person that you really have, as long as they're accessible, you can have video chats, they can be on the phone, they can talk to the doctors, then if that's the person you choose and that's the person that you think that you need, 2,000 miles away is workable, as long as they're not climbing mountains and they're out of range all the time.
Yeah, maybe not on Everest,
but if that's the person that you
But
have.
it might be good to have a local person, at least to be a liaison.
Yeah.
You have a question in the back there?
Yeah, this is a scenario that I'm much more familiar with by way of television. The horrible situation where mom or dad are in a hospital bed and there's no insurance or very little insurance and not much income in the family, and the medical practitioner is saying we can do to maintain this person's well-being and quality of life, and the DPOA has to make the decision, but there are no resources for the family to manage the person once he or she is home and can't walk or can't feed him herself. So who, is dramatized on television, right? But in real life, who's the decision maker in that position?
Yeah, and I don't want to gloss over the fact that we all love insurance so much and it works perfectly. Stay tuned for an August health and wellness seminar where we're going to talk about insurance terms and logistics. But seriously, I think the perspective that our care teams take, it's not that we can't do something like a cost estimate, but our providers and our care teams are not like, all right, Michael, do you want IVs today? It's going to be $800, right? We are focused on the patient and their care. And also to bridge those gaps. So if you're talking about something like you're going home and you need visiting nurses, what resources can we give to you? Can you get on Medicaid? Can you use our mobile integrated health team who comes to our homes to, draw labs or facilitate an office visit? We have our financial assistance program here for charitable care, right? So income qualifying. But I guess my main point is that we, as the healthcare team, are not dictating, like, can Michael afford this injection or not? We are thinking, does Michael need this injection? And then I'll harp on again, make sure your decision makers are aligned with you philosophically too. If you're the kind of person who's like, if that costs over $20,000, I'm out of here, you can talk about that. But I wouldn't anticipate the healthcare team approaching it from that angle. Does that kind of answer your question?
Yes, it does.
Yeah.
Thank you.
So is everybody ready to fill out their advanced directives?
We do have a couple of notaries here
Yeah,
tonight.
we do.
There's blank paperwork and information packet of the conversation starter guide in your packet as well. We felled so many trees for tonight for you. So if you don't personally need the form, maybe it's an olive branch to give it to a family member who you know might need it, or a child. Maybe you're talking about yours with your child, but they don't have one. If they're over 18, they do need one.
I can have one question specifically about, when I've gone in for like a colonoscopy, I'm gonna be put under. Doesn't the team or going through registration have you sign something? Maybe it's just giving the names of, people to contact or whatever. That's not the same thing as.
That's not the same thing. No, that's like an emergency contact or the person who drove you there so that they can give them a call and let them know that you're ready to, yeah, that's a completely different form. Yeah.
Real quick, only because Dr. Shippey brought it up, for all of you that have children or grandchildren in your lives that are over the age of 18 and whether or not they should have the conversation about an advanced directive. Last week, we were reminded of a landmark bioethical case that went on for over 20 years. A mom and a dad fought to have their daughter removed from life support. She had been in a very tragic accident. I think maybe she was 20 years old in Florida. And because they had no documentation or anything, they put her on life support, and she existed that way for all of those years while they took this case through the court system, right? So I know it's a hard thing to think about when your kids are, I've got a 24 and a 21, right? And last week after reading that article, we're going to be having a conversation, because it really is that important, so.
Thank you.
Yes.
Yeah.
Thank you all for coming.